Just make sure that I have my good evening, everybody. Welcome to another edition of our COVID knowledge exchange for Pune. This is Operation Breathe. And hopefully this is all designed to help Pune and Punekars breathe easier in this COVID times. I know that the COVID second wave seems to go up and down some, so it's still very relevant. I just want to say that our format, this is not a webinar, this is not a grand rounds, this is an exchange of information. So this only works when all teach and all learn. So today we have an exciting program. Dr. Sanjay Lalwani, who's the chair of pediatrics at Bharati Vidyapeeth, and Dr. Monica Vasudev, who's a pediatric immunologist in Wisconsin, and they will tackle the important issue of vaccines for COVID and what's the current state of things. So please post questions as the conversations are going on. Before we get launched, I just want to ask Dr. Akash Shinde to quickly give us an update on Jepaigo and what they're doing for capacity building. And there's been some exciting new things. Can you, Dr. Shinde, quickly, please?
Yeah, hello, good morning and good evening to all. So as Sir said that, so Jepaigo is helping Pune district government facilities for the capacity building of staff for COVID-19. We have started with the weekly 1-hour lecture series for the nursing staff. Every Thursday the session are there. Along with this, on this Friday, we have planned 1-day critical care training with support from Bharati Vidyapeeth, and Dr. Iyer sir and his team will be taking that session. And it will be a whole series of sessions which will last for around 3 weeks. In addition to that, we also had one meeting yesterday with the Dr. Bhakti Sarangi from Pediatric Department, and we are also exploring ways to build capacity of pediatric department in terms of monitoring of pediatric critical patient and use of equipments. So number of things are in the pipeline, and by the end of this month, we'll be having a huge programmatic update in terms of capacity building and overall program improvement.
Thank you. And quickly, the other things that we really have to move the conversation on is long COVID. We had a very nice session on it last week, and we're waiting for some international protocols and to bring those to Pune and really put Pune in a leading role in India in long COVID and also in some clinical trials. So stay tuned. And over to you, Dr. Lalwani and Dr. Vasudev. You have control of the session going forward. Thank you.
Thank you, Dr. Krishnamurthy. Thank you, Jepaigo and ECHO Project Breathe for the opportunity to speak today. I will be sharing my screen right now, and Dr. Lalwani will give the India update and regarding vaccines after my slides. So I will share screen. Are you able to see my screen?
Yeah.
Yes.
Okay. Thank you again. So it's still July 6th for me, so I'm still going to claim that date. Every discussion regarding vaccines and immunity requires a discussion on herd immunity, also known as community immunity. And this is a concept whereby if you have a population that is immune, you will also have the ability to stop the spread of disease. This is a diagram showing 3 scenarios where you have no vaccinations and 2 scenarios of 75% vaccinations with 2 different R0 factor. And as you recall, R0 factor is a number of people who are susceptible to infection by one person who's infected. How many people can you spread the infection to if you are infected. The blue dots represent individuals who are susceptible to infection. The red dots represent those who are infectious, and green dots are those who are immune, either by prior infection or by immunization. The R naught factor of 2 represents the initial coronavirus that we had at the beginning of the pandemic. That's when the R naught factor was around 2 in an unimmunized population. And you can see the solitary red dot here. And as infection spreads, it has the potential to surge and infect an entire community. When 75% is vaccinated and you have an R naught factor of 2, which is what we hope with our immunization efforts, as you can see, if one person is infected, you really don't affect a lot of people in the community. So you've achieved community immunity. However, when you have an R naught factor of 5 and you have an infected individual, you now have the potential to infect every single person who is not immune, either through prior infection or through immunization. Now, this is a very simple diagram, but the current Delta variant has an R naught estimate of 5 to 8. And if we have unimmunized populations, knowing full well that immunization cannot give 100% immunity to prevent infection, we are still in a scenario where we are racing against time, trying to get the best immunization efforts out there. And that's what today is all about. Vaccination is truly the light at the end of the proverbial tunnel. I want to talk about what is the immunity from natural infection. So this is not from immunization. The reason I bring this up is because of the intense effort to obtain antibody levels for people, whether it be through infection or whether it be through immunization. But immunity is not so simple by just measuring antibodies. This was a study that looked at memory B cells, the cells that are responsible for making specific antibodies, looking at specific antibodies to the receptor binding domain, which is the important part of the spike protein, and looking at 2 different T cells, the CD4 T cells and the CD8 T cells. And as you recall, a T cell, which is a type of lymphocyte, is identified by the cytokines or the hormones it produces. For example, CD4 T cells will make IL-4, IL-13, IL-5, and you have CD8 cells that can produce interferon gamma. So based on these 4 different parameters of the immune cells, they looked at people who had been infected with the SARS-CoV-2 virus at 1 month and 6 months after infection to look at these 4 variables. And as you can see, this diagram is depicting that immunity is variable, that everybody can develop a different type of immunity, and that pattern of immunity changes after 6 months. So measuring antibody levels is not the only story when it comes to measuring immunity. So what are we looking for with an endpoint of an efficacious COVID-19 vaccine? And again, this is in respect to having the incredible high morbidity and mortality associated with the Delta variant. You get exposed to the SARS-CoV-2 virus, you're hoping to prevent infection. Now, prevention of infection we know is through social distancing, hand washing, mask wearing. If we don't prevent infection, we're hoping that the infection remains asymptomatic. And we are seeing that if you are immunized, then it is possible to maintain the level of symptoms at a lower level. If you do get the infection, you're hoping to prevent the COVID-19 disease. You're hoping to prevent hospital admission. You're hoping to prevent ICU admission, critical care resources such as oxygen, such as ventilation. And of course, you're hoping to prevent death. And of course, you're hoping to prevent transmission. Now, we have experienced every single one of these steps in these surges at different time points, and we are still recovering from the recent surge that was earlier this year. So I don't want to spend a lot of time talking about the different types of vaccines, but as you can see that there are many different types of vaccines relying on different physiological or biochemical properties. And this has brought together and culminated an incredible time point in history where we can see how the effects of prior research and current knowledge has been able to bring about many different types of vaccines, which are critical in addressing this pandemic. You have the DNA-based vaccines that require a special system to inject the DNA into the arm This is in the works of potentially coming out in the next several weeks. We don't have any right now that are currently in use. We have the RNA vaccines, which have received an intense amount of attention and research efforts. 2 of these vaccines are available in the United States and in other parts of the world. They include the Pfizer-BioNTech vaccine as well as the Moderna vaccines. These are 2-dose vaccines, mRNA included in a lipid nanoparticle that's injected and requires a booster dose. You have the inactivated vaccines such as the Sinopharm and the Sinovac, which are commonly available in other parts of the world. You also have the well-known viral vector vaccines that have also received an intense amount of attention and research efforts. That includes the AstraZeneca Oxford vaccine that is actually being produced in your backyard, as well as the Johnson & Johnson vaccine that is available in the United States as a single-dose vaccine. These are viral vector vaccines, and they have been associated with a very low risk of blood clots that you have heard about and are currently being monitored. The new vaccine where there's been new research available for is the subunit vaccine, which is the Novavax, which has been found to be effective and also has been effective against the variants of concern, including the Delta variant. And then you have the live attenuated vaccine. I like this slide because it summarizes a lot of information. I apologize for not going into any more detail regarding this, and I will continue. So the other thing that is very interesting about the vaccine development regarding the COVID-19 vaccine is the short duration in which this was done. And that again, like I said, was a reflection of the amount of knowledge that we have today, as well as utilizing existing platforms for vaccine development. I also feel that this represents an intense amount of collaboration between industry and research institutions, which was unprecedented in our lifetimes. This slide shows you the timeline that has been required for the development of various vaccines that we've had in our history. You can see typhoid took 105 years. HIV, which is one of the most recent viral infections, still has research ongoing despite 32 years of research in developing a vaccine, and COVID-19 was 1 year. Eric Topol presented on his Twitter account, and he's very active in commenting on the current state of the pandemic. The timeline from the first COVID-19 documented illness, in parentheses, you have the unpublicized date, up until the time where we had FDA emergency use authorization for both the mRNA vaccines, and how we had phase 1A vaccination beginning for healthcare professionals. That is an incredible timeline to be witnessing in our lifetime. Just a little bit more detail about the mRNA vaccine. It utilized new data known about lipid nanoparticle technology, stabilizing the mRNA injected into its host. The mRNA is picked up by the host cell, utilizes its own ribosome machinery to produce the spike protein that is presented and stimulates an immune response. This is in contrast to the viral vector vaccines, and that again was the AstraZeneca vaccine and the Johnson & Johnson. This uses a non-replicating viral vector and includes the inclusion of the spike gene material that is then injected into the host. The viral particle is taken up by an antigen-presenting cell, such as the macrophage, dendritic cell. It's then broken down. The protein is then presented on its cell surface, and through MHC class restriction elicits a very sophisticated immune response. And this is how we develop immunity. What is the state of immunization to date in the world? This graph represents data as published as of July 4th, 2021, where at least 1 dose of vaccination has been administered in each country. The darker the color, the blue, the more the percentage of individuals that have received 1 dose of the COVID-19 vaccine. As you can see, Canada has a very strong blue color. They actually did a very interesting thing. They immunized all their healthcare initially in January and February, and then there was a shortage of vaccines. They have Moderna, Pfizer, and AstraZeneca that's currently licensed in the country. Due to initial reports coming out of England and data that came out of Israel, they actually extended the interval between the two Pfizers and Modernas from 3 or 4 weeks respectively, up to 16 weeks when they had a shortage of vaccines, hoping to get more of their population to receive one dose. When additional shipments became available, they allowed the interval to shorten. They also allowed mixing and matching of their vaccines. So they really made their vaccine program accessible to as many Canadians as possible. So what do we know about the vaccine against the Delta variant? So this is information that came as early as the 10th of May at 25 people who received both doses of the mRNA vaccines. And what they stated is that there was enough antibodies to neutralize the variant, where the immune response was being assessed by antibody production. This was a preprint. This has not been peer reviewed. And what you can see here from the 28th of May, that the Pfizer, which is your mRNA, and your AstraZeneca, which is your vector vaccine, after 2 doses was 88% effective towards the Delta, and only 33% if you had received 1 dose. So this really emphasizes needing both doses in this type of vaccine. India also presented or released some recent data just 3 days ago regarding the Delta variant and Covaxin. This was released July 2nd. And what it shows is that it has 65.2 protection against the Delta variant. I do want to make a statement too. There was actually a news release today that I haven't shown that the Delta variant and the use of the mRNA vaccines was also found in the similar range of the mid 60% in updated Israel data. So the Covaxin data is actually pretty at par with the mRNA data that we have from Israel. The other concept that I want to bring about is the concept of hybrid immunity, and where hybrid represents the combination of having previously had SARS-CoV-2 infection followed by immunization. We know that if you have natural infection, that the immunity is variable. Some people can have very strong immune responses and some people can have very weak. We know that people who are hospitalized and have severe COVID-19 disease, that they can have a much stronger immune profile compared to somebody who's carrying an asymptomatic infection. We also know that those who receive vaccine can have a homogeneous and strong immune response. But what happens if you've had infection plus immunization? You have what's known as hybrid immunity or hybrid vigor. And so what they found was that there was a 25 to 100 times higher antibody response that was driven by both memory B cells, so the cells that make antibodies, and CD4 T cells, which helps B cells make antibodies with cross protection from variants. So this is the argument for those people who've had prior infection and says, oh, well, I'm already immune, I don't need immunization. And this is what I explain to my patients that are questioning whether or not they should receive the vaccine. So what about the use of knowledge about data from India? And what we know is that those patients who've had recovered from COVID-19 and then received a dose of Covishield, that they actually had much better immunity than those who had received 2 doses of Covishield. And this was data that was published, on 2nd of July, 2021, and it included researchers from ICMR, the National Institute of Virology from Pune, and the Department of Neurosurgery Command Hospital at AFMC. What about the concept of mixing and matching vaccines? So I had mentioned earlier that one of the reasons that Canada has had a very high rate of those who've received at least 1 dose of vaccine is also that they've removed the ability to limit the second dose of the vaccine to what you had as your first dose. But what is the outcome of doing so? This is data from Spain that showed those who received the AstraZeneca vaccine followed by the Pfizer-BioNTech vaccine. It included 663 people. And what they found is, as you can see in those in the orange bar, that they mounted a much higher antibody titer starting 7 days after their second immunization compared to those who received the same dose. Dose of the same vaccine. In the COMCOV data, which was the one from the United Kingdom, they compared those who received the AstraZeneca alone versus those who received AstraZeneca and then had Pfizer 4 weeks later. And they were found to have an increase in antibodies to the spike protein. And this was posted on the 25th of June. So this is recent data as well. The Novavax, this was that subunit protein vaccine that I had talked about earlier. And this is based on familiar technology that has been used for many years, including the hepatitis B and the pertussis vaccines. This requires 2 doses, 3 weeks apart. It was found to be efficacious 90%, and it was found to be 91% protective in people to be deemed high risk of a bad outcome of COVID-19 infection. And what's really important is that they found to be 93% protective against 8 circulating variants of concern. This vaccine has a potential for worldwide use. It can be stored in a refrigerator for up to 6 months, and once removed, remains viable for 24 hours. This really reduces the potential wastage and makes this accessible in areas that may not have been able to receive vaccines because of the cold storage requirements with other vaccines. So what do we know about potentially giving a 3rd dose? I'm just showing this as an illustrative example of one scenario where a 3rd dose has been found to be helpful. We do know that there are other places in the world. I heard that in France that there is a program to give a 3rd dose who are immunocompromised. So what they found was that there was increase in antibody levels in those who received the Pfizer vaccine after their 3rd dose in patients with hemodialysis. And the 3rd dose enhances the humoral response. A humoral response means antibody response in almost all patients, especially in those with lower antibody titers after receiving 2 doses of vaccine. And this was published in Kidney International and was recently published. A note about pregnancy and lactation, and I know that the slide is old even as I'm presenting it. This is information that was available online as of 24 hours ago regarding the Johns Hopkins project to assess what are the global policies on COVID-19 vaccine in pregnancy and lactation. And what you are finding are different colors based on the level of recommendations. So in green, it's recommended for some or all. As you can see in Australia and Canada, Mexico, it is recommended for all. In the blue, light blue, you see it's permitted like in the United States. And then the reddish color with the fluorescent purple outline is not recommended or in transition. And you can see that applies to India. And I know that that policy has recently changed. So we are beginning to see an increased acceptance of the use of these vaccines to protect our mothers, our new mothers, and our lactating mothers. And this is just my last slide, where this is a publication from the Journal of American Medical Association, where they're showing you that there is the detection of antibodies in the breast milk after the 2nd dose. And so that there is benefit to the infant from their nursing mother based on the detection of both IgA, which protects the mucosal surfaces, and IgG antibodies, which are your most common antibodies. I just wanted to give you an overview of the vaccine state as it is today. I hope that this gave some information, and I'd like to pass on the presentation now. Thank you.
For people who are posting questions, please keep posting questions so that the speakers, experts can respond to them. Dr. Lalwani.
Yeah, good morning to all of you in India, and good evening or good evening to all in the US. After Monica's presentation, she just gave an overview of what vaccines are in offering, what is the mismatch vaccine, is it better, efficacious. I'm just going to give you a snapshot of what's there in our country. Now, I think one of the concerns what she expressed was the RO, reproductive rate. And if you look at the biggest concern with any virus is the mutation. And what we are looking at is the mutation strain Delta, and now we are talking at Delta plus. Now, what we saw a second surge in India was because of the mutation of Delta, where the RO went from 2 to 5, and if Delta plus. So the concern is if you have a population which is unimmunized, and if you have a variation in the vaccine, in the virus, and if the RO becomes much higher, the disease is going to spread much more faster and affect a larger population. So when it comes to a country like ours, we need to understand two aspects. What are the vaccines in offering in India as on today? And what is the roadmap in next 6 months? And second, of course, bigger challenge is such a huge population of our country, how the government is going to have its policy decision to vaccinate 75% of the population by the year end. So I'm just going to take on these things, and then of course it will be open for question answers, and I and Monica would take it, and of course if somebody would pitch, it's most welcome. So if you look at the vaccine agenda, what were the vaccines trials? What are the vaccines which are rolled out as on today? It's an emerging field. Every day the information gets loaded on the various networks, and we just present to you what's there. In India, the 3rd January 2021, the DCJ approved the Covishield AstraZeneca, which is a vector vaccine, and this vaccine is going to form 75% of the cohort in India is going to be vaccinated just because of the large scale production which is done by the Serum Institute. And second, of course, the indigenously produced vaccine, which is the wholesale scale vaccine Covaxin by Bharat Biotech. And and both of these have a restricted use in an emergency. The same vaccine, the pediatric study is going on at various sites. On 12th April of this year, the Sputnik vaccine, which was developed in Russia and of course imported by Dr. Reddy's laboratory, and it's been given in few places in India, and few sites in India have started the production of this vaccine. One of the limiting factors.
Dr. Lalwani, could you turn up your volume, please? Thank you.
One of the limiting factors, of course, is the availability of this vaccine, which is a concern. The vaccine in the pipeline for India, which has just got the emergency approval, is a DNA vaccine. The Zydus is the manufacturer, and its phase trials are on. Emergency clearance is given. The only limiting factor is that this requires 3 doses, 21 days apart, and you require a jet injector to be there to give this vaccine to the population. It has been licensed above the age group of 12 years. So this could be probably the first vaccine in India which could be available above the age of 12 years. Biological e-COVID-19 vaccine, the phase 1 and phase 2, and I think they are looking at this vaccine to be rolled out by the end of August. We have an intranasal vaccine by another Indian manufacturer for which the trial phase 1 are on. COVAX, I think what Monica talked about was the vaccine, which is a subunit vaccine, which is Novavax internationally, and in India it's COVAX. The phase 2/3 study, the SUN, I think we are going to start the study in the mid of July for the children above the age group of 2 years and above. And this could be the first pediatric vaccine above the age of 2 years, which would be licensed in our country. Then the vaccine, which is mainly in the developed world in the US, is the mRNA vaccine by the Pfizer and the Moderna. We have an Indian company and a researcher from Pune where these vaccine trials are started, and the phase 1/2 of the clinical trials are in going just now. So once the vaccines are going to be available, the biggest challenge was there was a vaccine COVID task force centrally, and they decided to roll out as the population is huge. We have no choice but to look at the target vaccination and save the vulnerables. So the phase introduction of COVID-19 vaccines, they were looking at 300 million population in phase 1. First, when it rolled out, it was the healthcare worker, then it went to a frontline worker, and then, of course, it was a high-risk population, those above 60 years, and those who were above 45 years with comorbid conditions. And this together actually contributed around 300 million population. The goal, of course, was to protect the public health, minimize the societal and economic impact by reducing the COVID-19. And based on the vaccine availability, which has eased out a little bit in our country, and the epidemiology, further phases are planned by the central team. So the first phase was rolled out on 16 Jan this year, where there were frontline workers. The second was on 1st of March and 1st of April, all above the age of 45 were included. The phase 3 was on the 1st of May, all above 18 years of age. And as Monica told in her slide across the map, on 20th May, there was lactating mothers, and now there are clear-cut guidelines issued by the ICMR that pregnant ladies can be vaccinated with any of the available COVID vaccine in our country. India launched its vaccination drive on 16 January, and till yesterday late evening, the 360 million doses were given to an Indian population. Phase 2 was vaccination for all above the age of 45. Phase 3 strategies was the vaccine manufacturer would supply 50% to the center and 50% to the state. And out of that 50% which is going to the state, 50% would be given to a private institutes to sell it into the open market. And those who could take it, it costs roughly around $10 a dose is what is the price given for the private market in our country as on today. Phase 4, Government of India will procure 75% of vaccines. These doses would be administered by states free of cost to all citizens as per the government rules and regulations. Domestic vaccine manufacturer will be given to take 25% of the vaccine production and give it to the own units, and the private hospitals may charge, of course, $2 as a service charge. So it costs $10 a dose for anyone who wants to take from the private market. So if you look at the number of people vaccinated against COVID infection as on 3rd July, if you look at the world and look at the India, the 11% of the world as on today has got 2 shots of COVID or fully vaccinated. 13% of them are partially vaccinated. If you look in our country, yesterday till late evening, 360 million doses were given, but 1.3 billion population, only 4.5% of them have got 2 shots and 16. So you have a long way to go, and government has a desire to vaccinate 10 million population per day. I'm sure they have a very ambitious target, but what is the data coming out is they are able to vaccinate 5 million population as on today. They need to see that 70% of the population needs to be vaccinated by a year end. It's too ambitious a project at this stage. Number of people vaccinated, of course, world we have 873 millions and 996 for single dose. If you look at India, the numbers are much more smaller as compared to the global map. The new journal, the NEJM article, preliminary findings of mRNA COVID-19 vaccine in pregnant women. Both the vaccines which were the mRNA vaccine were used by Pfizer and Moderna, and the pregnant ladies, actually 30% of them got in the first trimester, 45% of them got in the second trimester, and the third trimester around 25% got. If you look at the pregnancy outcome, there was nothing different. The rate of spontaneous abortion and stillbirth were same as those who were not vaccinated, and live birth were 86% after vaccination in third trimester, and the preterm and the SGA contributes around 9 to 3%. So I think there was not much difference between those who had not vaccinated. The NTAGI committee gave the clearance on May 28th that all pregnant ladies and all lactating mothers should be given vaccine, and the safety is there from the baby's perspective and the mother's perspective. Then we have this Covaxin started in the Central Institute in Delhi. The Serum Institute of India has started the clinical trial of Novavax above the age group of 2 years to 17 years. And they have a roadmap to roll out this vaccine by the end of the third quarter of this year in India. Now, what Monica told about the mixed match, I think that is a big concern in India because the number of vaccines, I think the larger rolled out is Covishield. There is still a shortage of Covaxin. So when she talked about the mixed match of giving AstraZeneca followed by the Pfizer, because in the Europe, it was the AstraZeneca which rolled out, and then they have the availability of the mRNA vaccine. When it comes to our country, there are concerns about mixed match, not because of the shortage of that vaccine or because of the errors which happen at the vaccination site, because a large population is getting vaccinated. So the country plans to have the trials on safety, efficacy, and mixing of the vaccine. A lot of data is getting unfolded. There are few papers which are coming out. I think we need to wait for some time to see that what data really comes out on this particular aspect. Now, the biggest concern was this vaccine is undergoing mutation, and day after day we are going to get various. Are those mutations going to have more reproductive rate? That's number one. And since the population at large is unvaccinated, we need to vaccinate a large number of population to see that they are protected. That's number one. Are those mutations going to be protected by the vaccine? And the data which Monica showed that is that Delta variant going to be protected by the available vaccine? So the Covishield vaccine and the COVID-19 recovered vaccinated individual, the efficacy for the Delta strain, I think is around 60 to 65% for the protection which is there. The slide which she presented, the study done by the NIV and the ICMR and the AFMC, the breakthrough cases and COVID-19 recovered individuals with 1 or 2 doses of vaccine had relatively a higher protection against the Delta variant in comparison to participants who were administered either 1 or 2 doses of Covishield. That means instead of having 2 vaccines, if somebody had got an infection in the past and he or she gets one of the vaccines, they appear to be better protected against the mutating strain of the COVID virus. The vaccination real world data from the UK shows around 65 to 88 protection rate after first dose if the interval is up to 12 weeks. When we rolled out the AstraZeneca vaccine in India, the initial duration between the first and the second dose was 6 weeks. But the task force, of course, took a decision. I don't think there was more of science, but I think it was more of the availability of the vaccine. The duration between the first dose and the second dose was enhanced to 84 days. So what's out now that anybody who has got COVID infection in the past, he or she has to wait for 3 months, and the duration between the first and the second dose in a country of ours has been enhanced to 84 days. This probably one of the factors which motivated this was the availability of vaccine and seeing that a large population at least gets the first shot of vaccine, and of course little bit of scientific evidence. Therefore, based on the real world evidence, dose interval were increased between the 2 doses of Covishield. There was no change in the dose interval of Covaxin, which is still at 4 weeks, and of course the Sputnik is at 3 to 6 weeks. And Zydus, which is going to be rolled out. Another issue is that vaccine has 3 shots and the duration between each of them is 21 days. To conclude, protection against Delta variant, I think the data is going to emerge. There are going to be mutations. Today we have Delta plus, then we will have Delta plus plus. I think we need to keep a close watch and see how the newer vaccines are going to prevent the infections from these mutations. The vaccine data scientific will be available in days to come. Is COVID vaccination going to be an annual vaccination till really the COVID wave settles down globally? We need to wait and watch whether, just like a flu vaccination, whether COVID vaccination also will be a part of an annual vaccination program in years to come from 2022 onwards. I think that's what a summarization of Indian scenario, and I think we are open to take the question from the audience. Thank you.
Dr. Lalwani, I might start with something that has been in the press quite a bit about myocarditis. What is your sense about the risk of myocarditis after the COVID vaccines?
There is a talk. I'm sure Monica would be able to show more light. I think as far as the Indian data is coming, there are not documented. There are concerns about myocarditis, but how severe it is going to be, I think we have to just wait and watch. Monica, you want to add anything on that?
Yeah, so far the data that we're seeing related to the myocarditis are found in adolescents, mostly in boys age 16 and older. The myocarditis is mild. I think a few of them had been hospitalized for monitoring, but they were found to have a very limited course. I showed the symptoms: chest pain, shortness of breath, and palpitations. I actually followed this very closely because I have two adolescent boys, age 15 and 13. And I waited a month after the approval EUA for Pfizer, waiting to see what the risk would be. And I have not seen any concerns. None of my patients who've received the Pfizer vaccine have had the myocarditis. I've also not seen any reports of this side effect with any of the other vaccines that we are utilizing, nor have I seen it worldwide. But I don't know if it's being missed because it's mild, but at any case, I've not seen anything significant. And I think we need to wait and see. Thank you.
I think, Dr. Krish, I think the vaccine has been licensed in a very short record period of 12 months. So I think initial concern was of coagulation disorders, then it was of myocarditis, then it is of GBS-like symptoms, some anaphylaxis. I'm sure as the vaccine is going to roll out in the population at large, post-marketing of phase 4, whatever you say, we need to keep a close watch. A lot of data will keep off unfolding, and I think we need to keep a watch on it. But let's understand the risk-benefit ratio. Vaccine is going to save a population at large, then the associated COVID morbidity and mortality. But at the same time, we need to be very, very closely monitoring all the recipients who take this vaccine, and any of those untoward adverse events, if they are recorded, we need to just keep a watch whether it's a causally related to a vaccine or it was by a chance of a normal population. I think we just need to keep a close watch on that.
Thank you. Dr. Jatana has a question about exercise recommendation. Dr. Jatana?
Yeah, just my question was, what is the recommendation on doing an exercise or exercising after vaccine? Because there was a recent report that one of our youngsters had died after taking Pfizer vaccine, exercising and doing a lot of cycling. So I just read yesterday. So what is the advice on that? Should one refrain from doing any exercises after the vaccine, or for how long?
To be very frank, there are no strong recommendation. I think they should do exercise. There's nothing with vaccine and exercise together.
I would also make sure that there was no other condition, like the patient didn't have HOCM, ASD, or any other pediatric cardiac anomaly that made them at risk. It's very unusual to have this because this has not been reported. There might have been a cofactor event that might have played a role.
Okay, thank you.
And you just answered eloquently on Guillain-Barré syndrome, because that's been a concern with other flu vaccines and many other vaccines, right?
Yes, I actually posted the information from the GBS Society to say that they are also recommending vaccinations. And I'm seeing this from almost every society. You look at American College of Obstetrics Gynecology, please vaccinate. You look at the Mastocytosis Society that looks at allergic reactions, because the other hat I wear is an allergist. please give the vaccination. You look at the GBS Society, they're saying no contraindication. So everybody is saying that we are having patients with our conditions and they're tolerating the vaccines, and we don't know how to risk stratify who are those that are at highest risk. I think the discussion about risk benefit ratio is not about vaccine or no vaccine. The risk benefit ratio is vaccine versus current virus. And the virus is changing. So that equation keeps moving, even if the risk of reactions is present, which will be present with anything. But I think the risk of infection is always going to be much more than the risk of infection.
Thank you. Dr. Lalwani, would you like to address the question of vaccine hesitancy in your practice?
Yeah, if you look at the rollout of the vaccines in India in various states and whatever data are coming out, the bigger concern has been the states which are thickly populated and the literacy level is a concern. So I think if you look at Uttar Pradesh, this has a population of roughly around 240 million, and those particular state is vaccinating the least. And I think vaccine hesitancy is a big concern in India. There's no doubts about it. We need to address it. It's in a great depth. There are a lot of videos getting circulated by the prominent personalities in the country to sensitize the population that vaccination is the only way to protect yourself from the COVID. But believe me or not, vaccine hesitancy was an issue even when the program was rolled out for pediatric vaccination in the National Immunization Program. The adult vaccination is a new thing in our country. It's not well really taken up by the crowd at large. Now, to roll out a program into a state which we refer to as Bimaru states, or states where literacy is a concern and they are thickly populated, which forms roughly around 50% of the Indian population. Now, biggest challenge is how the government is going to roll out and see that at least 50%, too ambitious a project to roll out the vaccination in 50% of population there. There have been a task force which have been created, which are looking at how to, the issue today is not more of vaccine hesitancy as on today, because the vaccine supply, they are now vaccinating roughly around 5 million population every day. And I think by the end of August or September, when they see that they have got one dose of vaccine, I think one of the biggest stumbling block which is going to come is a vaccine hesitancy, and the preparedness for vaccine hesitancy 2 or 3 months in advance needs to be given. And I think there are going to be social medias which are going to be used, political figures are going to be used, religious members in the community do form a big part of influential. So I think where we have the community active workers are going to be playing a main role and rolling out there, and they are going to be our role models for the population to roll out the vaccine at our country. I think that's going to be a big challenge. We look at countries like states like Maharashtra. So if you look at the whole of the country, from Western India down south, the vaccine uptake is going to be good. From Maharashtra up towards north, the government and the center team will have to really focus because the mortality and the morbidity undocumented has been very high in the northern states of our country. And I think rolling out vaccine is going to be a big concern. There are roadmaps being made for it. And I think there are going to be, and the only way to roll out is social media, political workers, religious workers, and the sarpanch of those areas, or the Anganwadi Sevikas or the Asha workers who are going to do a ground level work at community. I think they are going to be having do a lot of groundwork and capacity building of theirs.
Thank you. So you mentioned an important point of role models, modeling behavior of taking vaccines. What other advice would you have for our primary care physicians in Pune about how to deal with the individual? What is your strategy when somebody comes to you and they say,
So what
Dr.
I
Nedina.
normally on the various platforms I talk, I think we are talking to all the physicians that whatever patients they are seeing in their outpatient department, the front desk of those clinics really ask each and every patient, have you taken the vaccine? If not, take the vaccine. Have your relatives taken the vaccine? What is our observation is still 50% of people have not taken the vaccine. And one of the concerns expressed was that the vaccine availability is an issue, but I'm sure it's going to ease out with time. That's number one. Number two, the concern is the vaccine supply is not continuous. It comes for 4 days and there are 2 or 3 days gap in the middle. So somebody has to take out a time from his daily wages and go for vaccine. So I think one of the issues which the local authorities here are looking at the continuous supply of vaccine. If in a city of Pune we have a continuous supply of vaccine, they are going to have a much better uptake. Third thing, I think there was a thought process looked at. He ask every patient coming to the OPD, have you not taken the vaccine, and make even the small setups in Pune available vaccine so that if they come to show a clinician and if he's fit to take a vaccine, inoculate him in that OPD itself. I'm sure we have only around 20 or 30 private setups today giving a paid vaccine. Those numbers are going to be enhanced by July end to 300 setups. I'm sure this will also increase the uptake of the vaccine. But let me be very clear, Krish, Pune is a far better place for vaccination. My biggest concerns are in the northern part of the country.
Got it. Thank you. And you made a very important point that as pediatricians, that every healthcare encounter is a potential opportunity to do a preventive vaccination, right? So this is one of the...
I'll tell you my observation. In our day-to-day OPD, we give a vaccine in my private setup here. We are vaccinating from a walk-in patient at least 200 plus patients every day. They come to show their babies and I tell mother, have you taken the vaccine? No, I am lactating. Has the father taken the vaccine? No, he has not taken the vaccine. So invariably, I think we pick up those first contact which comes on our OPD basis. I think we should not miss an opportunity to vaccinate every individual by sensitizing him the importance of vaccine.
So
there are a lot of myths about the people. I think our job is to clear them of their myths and misunderstanding and motivate them to take vaccine.
So this goes beyond what we've done as pediatricians for the longest time, is not only vaccinate the child, but also vaccinate the adults, in that encounter. So India is many countries all at the same time coexisting. So I'd like to pull in Dr. Vasudev to see what is your experience with vaccine hesitancy and what have you, how have you approached it?
Thank you for that question. So in the initial phase, when vaccines were first brought out for phase 1A in December, January, we had very difficulty in getting the invitation to schedule the vaccine. Vaccines have been in the United States only been allowed to be given in certain areas, and they are not available in my clinic. They're only available in pharmacies, they're available in hospital settings, they're available in mass administration settings that have been identified, or in places of worship. You'll see many churches, gurdwaras, temples that are giving the vaccines. Now, so when I am addressing vaccine hesitancy, I don't have the ability to have a captive audience in front of me, nor do I have the ability to vaccinate other family members just by virtue of the system that I'm in. We have a little bit different rules in how we do things. But I think the first question, or the way I deal with it, is I have access to their immunization status that is logged online. So I know whether or not they received it. So all of my patients have every immunization, at least in where I live. So I know what they have not received. If they've not received it, I acknowledge it. And I say, I see you've not received the COVID-19 vaccine. I just want to know what is your thoughts about getting it? Are you getting it or not getting it? And if you're not, why not? So I explore the reasons that prevented them from getting the vaccine in the first place. And then I give them my explanation as to why it is good for them, whether or not they've had COVID before, whether or not they have an immunocompromised person in the house, whether the fact that their fear and anxiety has prevented them from leaving the house, but I will try to identify one part of their life that can get better by getting immunized. And then I try to tell them where they can get the immunization without it being such a burden. How successful have I been? I don't know, because I haven't seen them to see whether or not they received the immunization. But we in the United States have an abundance of immunization. So we are now dealing with patient population who've not been vaccinated and have chosen very clearly not to get it. So I am dealing with that level. These are not the, oh, I don't have time, I don't know how to do it, there's no vaccines available. These are the people who are saying, not me, I don't want to do it. So harder population to address.
Sure. Now, what about people who are waiting?
Yes, they're waiting for more information. So when they say they're waiting, I ask them, what are you waiting for? We had data from Pfizer and Moderna of 30 to 40,000 people. We've had millions of people who get it. And then when they say that they're scared of side effects, which is the most common reason for vaccine hesitancy, or that's what they're telling me, whether or not that's the truth, I then bring up, are you on oral contraceptives? Do you smoke? Do you vape? Do you do any of these other behaviors that put you at higher risk for similar side effects? And then when I present it to them, then their response to me is, well, I choose to do this and I don't choose to do that. The other thing that I compare it to is whether or not they get the flu shot. And then I look at their vaccine behavior, whether or not they take an optional vaccine like the flu shot. In the state of Wisconsin, we have about a 50% vaccination rate with the seasonal flu. So I'm already dealing with the population that chooses not to get. And I deal with respiratory diseases. I deal with asthma. 90% of my clinical flow is asthma care. They have respiratory concerns. If they're not getting the flu shot, then I know that many of them who haven't chosen to get the vaccine won't. I have many nurses as patients. My nurses have not gotten vaccinated as well. This is a problem that we have to address with knowledge.
So your answer is we just keep on educating people. Thank you. Dr. Kinjalk has a question. Nishindra? Can you unmute yourself?
Sir, am I audible, sir?
Yeah, you're audible, yeah. Mm-hmm.
Sir, I did not have a question. It's a practical scenario that like Covishield vaccine has got one vial, has got 10 doses. So in unsupervised centers, what you do is that they give you 2 doses or 3 doses, and whatever is remaining, they put simply inside the that cold chain box, and that is being used, say, even after 1 day or even after 2 days. So I believe that whatever report we have, that it must be used within 4 hours. So we are now in the as Dr. Lalwani said, we are going to give vaccine to the private centers. So it will be a difficult issue ensuring that the vaccine potency does not go down, and all the instructions, especially about its efficacy, are followed up properly, because this is very rampant. I've been seeing it, especially in the private centers. So that's what was a comment, number one. And number two, a question from the experts, whether this can be practiced or how to curb this or how to stop this. Thank you.
So,
Lalwani, yeah.
Kinzaka, I think the recommendations, we rolled out the vaccination at the medical school way back in the month of March or February. The guidelines are very clear. It's a 10-dose bulb which is there. You need to open it up and use within 4 hours.
Exactly.
They do not recommend to use. That's the vaccine which remains in the bulb, needs to be discarded, and they are calculated as the wastage doses. Now, if we are going to give it to a private setup, which are going to inoculate a far less population, the wastage is going to be more. So the suggestion which is there is that you pull up the patients, and if you have 10 patients collected in the OPD, then only you open a bulb. So when the government is going to roll out the vaccination program, they have the information which they have asked from the centers is how much amount of vaccination do you see to take every day. They are not going to give up left, right to any centers because they cannot afford to have the wastage of the vaccine in our country. Let's be very clear. Number two, it's not going to be rolled out in small clinics or like this, what we do in our program, which is done at our day-to-day practices. It is going to be rolled out in an hospital, which are minimum 20 beds. It is not going to be given on the OPD basis for the follow-up. It is going to be given in the hospital, which has the IP services as well as the outpatient services. So as on today, it is very clear that you have to accumulate the number of subjects who are going to get vaccine in at least multiples of tens, and then only you need to open the vial. Or you start the day of the vaccination from morning 9 to 4 is the normal session. They say that after 2:33, if you have only 10 patients, then only you open up the vial. Otherwise, you will end up giving 1 or 2 shots of vaccine and remaining 8 will go a wastage. I think those are issues which are going to be dealt. And I think they are working on this minutely. And I'm sure the cooperation would be sorted by every medical practitioner who is going to practice the vaccination. And what we do at our setup, at my private setup, or even Bharati, where the volumes are more, we don't inoculate or open the last vial unless we have 10 patients beyond 4 o'clock to see that the wastage is minimal.
Thank you. Dr. Akash Shinde, Dr. Shinde has a question.
So my question is both to presenters, how you are dealing with, or have you come across clients or patients who are absolute contraindications for the vaccine because of due to allergic reaction to vaccines or injectables in past? How you are dealing with such cases?
See, we have, at least in our center, we have not, it was initially it was pregnant ladies and the lactating mothers and less than 18 years of age, but each one of them has got the vaccine because vaccine has to be given in those which are at high risk because the mortality and morbidity are there. Those who have very high risk or those who have anaphylaxis to any other drugs or eatables, I think after giving vaccination, we are holding in those areas with a far larger period of time under observation. So at our center, normally they wait for half an hour after the shot. If somebody has a history of allergy or anaphylaxis to any drug or injectable in the past, which is by the history per se, or it is documented on the papers, then we are giving the vaccine and we have the enough amount of space to hold those patients for a longer period of time, maybe for 3 to 4 hours. That's what we are doing it.
Thank you.
So I can speak on that as well as a practicing allergist. So we were given early guidelines regarding the excipient inclusions of chemicals in the RNA viruses vaccines. And that included 2 agents. One was polyethylene glycol, and the second was polysorbate 80, which are both cross-reactive. Polyethylene glycol is in the bowel prep that we use under the name of Miralax here. And polysorbate 80 is a stabilizing agent that is found in multiple medical agents, including injectable steroids, eye drops, our hepatitis A vaccine. So there was a protocol that was released by Dr. Banerjee at Harvard University in Boston, and she proposed, that was paper published in the Journal of Allergy and Clinical Immunology, whereby we went by and we skin tested percutaneously and intracutaneously to different compounds that contain polysorbate 80 and polyethylene glycol, including Refresh eye drops, which is used for just dry eye, hepatitis A vaccine, Solumedrol, things like that. Ultimately, in the evaluation of patients who had first dose reactions in my clinic, only 1 patient had positive skin tests to agents. The rest of them had negative skin tests. I then tested them to spike protein antibodies to see whether or not they developed any immune responses. They all had high spike antibodies and undetectable regular SARS-CoV-2 IgG levels. What we now have in updated information is that the prevalence of polysorbate 80 and polyethylene glycol allergy is much higher than the rate of reactions to the COVID vaccine, and we're back to square one. That there is no predictor as to who is going to have an anaphylaxis or an anaphylaxis-like reaction. We've heard of cases of people getting Moderna arm, which is the redness and the localized redness. They get it after the first dose, and second dose later, they're able to tolerate the vaccine without any reaction. So we know that this is an immunogenic reaction, but whether or not it's an IgE-mediated hypersensitivity reaction is yet to be seen. The patients that I don't push whether or not they should get the vaccine and who is the exclusion, which is what your original question was, people who reported reactions to injectable vaccines or have skin tested them to vaccines itself, and they had a positive reaction. But if they have like mast cell activation disorder, or if they have idiopathic anaphylaxis, or if they have other issues that they've been evaluated for, I pre-medicate them with cetirizine, which is an H2 blocker, as well as famotidine, which is an H1 blocker with an H2 blocker. And then I tell them that if there's any issues, that you should get your immunization in a hospital-based setting. They have my phone number and they call me if there's any issues. And to date, I've not had one patient who's called me. So either they're not getting the vaccine or they've not had a reaction. So I think that we don't have enough information. And as we're getting in immunizations by different mechanisms of action, the pathophysiology of these allergic type, we call them anaphylaxis-like reactions, is hard to predict.
Thank you. Any additional questions or any final comments by the experts or anybody else in the audience?
I think whoever are the part of this discussion, I think from India, I think the most important is to see that more and more subjects get vaccination. Please keep on spreading the word. It's very, very important to take the vaccine. I keep a close watch on vaccine manufacturer because we do a lot of clinical trials on vaccine. We are going to have a rollout of vaccines to roughly around 10 millions a day, maybe by the 1st of August. Only thing is that we should reach the masses, and please contribute to whatever best you can to remove this concern of vaccine hesitancy, and see that whoever you come in contact, one of your line of conversation should be, have you taken the vaccine? If you have not taken the vaccine, please go and get yourself the jab. I think if we can contribute, each one of us, I always say to all my hospital staff, each one of you should motivate 10 people to take vaccine every day. And I think each one of us start doing it. I'm sure we should see this world, and especially a country of ours, to be out of this pandemic to a great extent by the year end, only if we vaccinate a sizable number of population. I'm sure a lot of data is going to unfold on the efficacy, the variants, but I think the vaccine is going to have a lot of benefits, and concerns about the side effects are going to be there, which are going to be far minimum as compared to the benefits. So vaccinate maximum people whom you come in contact with, and pediatric vaccinations are going to be in India, going to be a scenario from 2022 Jan. I don't think so that pediatric vaccines are going to be a part of the program this year. They are going to be a part of next year. So all mothers needs to be told that the children will have the schools from their homes for second year consecutively. So the psychological impact on the children is going to be a bigger concern, which will have to be dealt with it. And hopefully by the next year, we should have a normalized things, which should be, I hope it really, we are back to the track normally next year in our country.
Thank you. And you would vaccinate adolescents, right? Regardless of the rare events of myocarditis?
Yes, I would vaccinate.
Okay. Thank you. We have several messages. I'm just going to look at it. Dr. Akash, you have a question?
You unmute yourself.
I asked the question when the session was ongoing. It's just my assumption or a hypothetical question. Having multiple vaccines and inoculating population with multiple different vaccination can pose a risk of global threat, and is it one of the reasons for the virus mutation?
Akash, could you pose the question again?
Yeah, my question is hypothetical, basically. Having multiple vaccines and inoculating population with different vaccines can pose a risk of global threat. And is it one of the reasons for the vaccine mutation, virus mutation?
I don't really think so, Akash. Monica, you want to add anything on it?
Yeah, I believe actually it is a survival benefit for the host, which is us, to have multiple different types of vaccination because your virus is constantly mutating. So we need to be multiple steps ahead. So even though vaccine one is good against virus one, maybe vaccine one will not be efficacious later and vaccine two will be efficacious against vaccine one. I think this is a beautiful thing that we have multiple vaccines, we have multiple different genetic populations, and that we're mixing and matching. I think that the more smorgasbord, the more variation we have in our vaccines, we can be one step ahead of the variations and mutations that we're seeing in the variants. I do understand your question. And that's why in the United States, so many people were saying, let's mix and match, let's mix and match. And the guidelines here was to follow the original studies. So they were reluctant to do it, but then the rest of the world showed us that mixing and matching is good.
Thank you.
Yeah.
Dr. Lalwani, what do you think about sending children to school who are not vaccinated?
It's a big concern. There have been recommendations coming every weekly, every fortnightly that the schools will open. I personally think so, that most of the mothers will not send their child to the school unless the children are vaccinated. That's number one. Number two, the school teachers and the adult population who looks after the children in the schools will take 2 shots of vaccine, but sending the children to a school is going to be a concern which the parents will always have. And I think so that the schools will start next year only when the COVID vaccination becomes a part of pediatric vaccination. But last thing, I must put it on the records as a pediatrician in the country, vaccine importance has really been in the limelight because of COVID. I'm sure post-COVID, this impact should catch up in the national immunization program, and the vaccination percentage would really go up in the country post-COVID. That's number one. It will open another area that vaccination doesn't only pertain to pediatric vaccination. The adolescent vaccination and the adult vaccination also would really come up post-COVID in a country like ours. This is what my frank observations are.
Thank you. Thank you. So I think that in the interest of time, we should, I know it's time for folks in Pune to leave for work. And any final, I think Dr. Vasudev, do you have any final comments?
I want to say thank you, everyone, for sharing your time. I know that this is a hard work just to even be here, and we appreciate all the feedback, the questions. I think we're all learning together. Thank you, Japaigo. Thank you, Echo. Thank you, Puna. I'm very grateful for being here.
Thank you. And please do join us next week, and we hope to be talking about variants. We started, Dr. Lalwani and Dr. Vasudev brought us a little bit of information about variants. We'll talk more about variants. So with that, thank you very much. Please do follow the link for questions. Dr. Shinde, can you put the link again, please? For the Google?
Yes, yes.
Okay. And so we will see you again next week. Thank you very much. Have a good day.
Thank you all. Bye.
Thank you all. Bye.